Hello, I'm Dr. Ben Anderson, Director of the Breast Health Global Initiative. What I'd like to speak to you about is the World Health Organization Global Action Plan and the role of breast cancer guidelines for low and middle income countries. Breast cancer is a non-communicable disease, meaning that it's not an infectious disease. It is a major global problem that we are addressing and need to continue to address. The United Nations in 2011 held a special meeting that addressed non-communicable diseases and set out a new goal of addressing non-communicable diseases in the setting of low and middle income countries. This movement is really changing the direction for global health care. Non-communicable diseases are responsible for 36 of the 57 million global deaths in 2008. The four major non-communicable diseases are cardiovascular disease, cancer, chronic respiratory diseases, and diabetes. 9 million deaths occur before the age of 60, and 80% of these deaths result from non-communicable diseases in developing countries. So we must address NCDs. Within this, cancer is a very prominent problem. Cancer is responsible for 4.4 million deaths per year, more than respiratory infections, respiratory diseases, HIV/AIDS, diarrheal diseases, and tuberculosis. And breast cancer among cancers is a key issue that we cannot overlook. Breast cancer is the most common cancer among women. And if we look at the period that is projected, 2015 to 2024, we know that there will be 17.5 million breast cancer cases diagnosed. We know that 9.1 million cases will occur in less developed countries. That is the majority of breast cancer cases. And by 2024, over 1 million cases of breast cancer will be diagnosed each year in low and middle income countries. Breast cancer is the most common cancer killer among women around the globe. Overall, 5 million women will die in the next decade from this disease. And actually, the majority, 3.6 million, will be in low and middle income countries. Of those 3.6 million, at least 650,000 deaths are premature and preventable. That is a lot of lives lost that we have the opportunity to address today under the Non-Communicable Disease Act of the United Nations and the World Health Organization. In fact, more women will die of breast cancer in low and middle income countries than were women's lives lost in the Holocaust. If you look at the data, you can see that the red line, which is breast cancer incidence in less developed countries, and the purple line at the bottom, breast cancer mortality in low and middle income countries. It is becoming and is a greater problem in developing than in developed countries. When we look at age distribution, overall there's a similar incidence between the more wealthy and the less wealthy countries. But actually in the youngest age groups, this is the most significant problem, where there is a clear dominance of breast cancer deaths in those ages 15 to 69. Among breast cancer. So it's a problem that specifically affects younger women when they are in their most productive years. So in response to the UN initiative, the World Health Organization has come up with a global action plan that is currently being reviewed by member states. They're soliciting member states for input, and this is a guideline for how our countries around the globe should be addressing different non-communicable diseases. If you look at the earlier version of this draft, we see that they talk about the reduction in modifiable risk factors, including tobacco, physical activity, obesity, saturated fats, and alcohol. They talk about disease registries, including cancer, if these are viewed as sustainable with appropriate indicators. The only place in which the term breast is mentioned in this it is in breastfeeding, where they recommend breastfeeding. This is actually not a major strategy for improving breast cancer outcomes. And overall, there are no specific goals or actions that relate to breast cancer early detection, diagnosis, treatment, or palliation. In the updated version, there is now a reference to early detection and screening, but it does not reference breast cancer in particular. And so with the current guidelines, we really cannot anticipate any improvement in breast cancer outcome, despite the fact that it is the most common cancer among women and the most likely reason that a woman would die from cancer. So now we have to ask, how can we improve these outcomes? This is what guidelines are for. Guidelines help us work our way through the management of diseases, and particularly cancer. The UN, back in 1966, passed a human rights law in which they said that state parties to the President Covenant recognize the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. They recognize that we can't distribute all health care in all places at all times. And it is factual that there is a limit to what countries can provide for health care in general. Indeed, the discrepancy is great, where in low-income countries, only $22 per person per year is spent on health care. And in contrast to lower middle, upper middle, and high-income countries, where a much larger amount of funding is available and spent. And so we have to consider adapted approaches that are realistic. Early detection of cancer is a huge obstacle in the setting of breast cancer. In high-income countries like the United States, the great majority, that is more than 90% of breast cancers, present as early-stage disease, that is stage 0, 1, or 2. And these are the cancers where we can make the greatest impact at the least cost. By contrast, in India, 3/4 of cancers present as locally advanced or metastatic cancer. These are the most advanced stages and very difficult to improve on outcome, even with all of the resources that are available. So clearly, downstaging of the disease, somehow getting cancers to present at earlier points where treatment is more effective, this clearly has to be one of our strategies. Ideally, we would prevent breast cancers. And prevention is, of course, an appropriate goal. But when we're not successful in preventing the development of a breast cancer, we have to go through a step of early detection, that is, finding it at its earliest stage, diagnosis, where we prove it's cancer, and treating it. Now, what about that prevention? We do know about risk factors, and some of them are modifiable, just as the Global Action Plan has asked for. So more breastfeeding, better physical activity, weight control, avoiding excess alcohol, avoiding excess use of hormones, and avoiding radiation. All of these are factors that have been associated, but they're actually very weak risk factors. And even if we could influence all of these, which typically are problems in high-income countries rather than low- and middle-income countries, even if we could influence them, this would only affect 20 to 30% at most of the cancers that we diagnose. So prevention is not a strategy for improving the outcome for the majority of cancers of the breast. Instead, we need to think about healthcare systems. How can we adapt healthcare systems to optimize the early detection, diagnosis, and treatment? And that has been the role of the Breast Health Global Initiative, to focus on guidelines that address this in appropriate ways. The BHGI created comprehensive guidelines by pulling together experts to review existing information about breast cancer and then publishing these results in a series of monographs. The first two global summits, 2002 and 2005, created the guidelines that we have today. The second two global summits in 2007 and 2010 then evaluated and validated these guidelines and to see, do they in fact work, using experts evaluating all of the available information to determine if these are functional. And probably the most important step that the Breast Health Global Initiative did was the creation of this concept of resource stratification. There's some resources that are more important and more valuable than others. Basic level resources were defined as those core level resources without which we cannot hope to make any impact on breast cancer. So for example, breast surgery is necessary for cancer. If we cannot operate on breast cancers, we cannot improve on outcome. Being able to prove that it's cancer, having some pathology evaluation that accurately diagnoses cancer, this is basic, without which we cannot improve outcome. Limited level resources were those that are resources that can be anticipated to improve outcome and specifically improve survival. So we have very high quality evidence about many of the drug therapies that we use that conclusively show that women will live longer on average when these are made available. Enhanced level resources are those resources that may or may not improve survival, but will improve options. So for example, breast conservation, where we perform a lumpectomy with radiation in place of a mastectomy. This does not improve survival. Mastectomy and breast conservation have the same survival, but it does improve options for the patient. It makes it more acceptable, and so more women may participate in breast cancer treatment if they're able to preserve the breast as opposed to losing it. And the fourth level, what we call maximal level resources, these are resources that tend to be the most expensive and the most complex. And while we tend to focus on them in our evaluations in the United States, they actually should have a lower priority due to the complexity and cost. So for example, breast MRI, which is a very useful tool, we're using it a great deal in Europe and the US to diagnose cancers. We can anticipate that MRI would make no difference in survival since there's no difference between removing the breast and saving the breast. So MRI would have a low priority in the setting of low and middle income countries. Using these four levels, we're able to take the standard resources that are applied to early detection, diagnosis, and treatment and put them in an order so that healthcare ministers, other key opinion leaders, and healthcare administrators can prioritize where they should be emphasizing their resources to have a functional system at a minimum cost. These guideline tables have become the basis of the Breast Health Global Initiative guidelines, where we lay out in those four tiers of basic, limited, enhanced, and maximal resources for healthcare systems, early detection, diagnosis, and treatment by stage. So this becomes a framework that groups like WHO or other healthcare experts could use in trying to make decisions on prioritization so that we can build systems that are functional and predicted to work. But we need metrics. Metrics, we have to measure whether we're making a difference or not. And while we want the ultimate metric of survival and quality of life to be those measures that we focus on, often in building systems, we have to focus on process metrics. That is, how effectively are we doing our work? How many women are getting through? How much access do they have to these different health cares? And we need to have measures of the cancers to see whether we're in fact making improvements in them in terms of early stage of disease. Metrics are very important in understanding how we're doing within a system. And the most fundamental metric that we've been able to identify for breast cancer outcomes is how large are the tumors, what we call median tumor size. When the median tumor size is quite large, then downstaging of disease is very important. When tumor size is small, then we're being more successful with that and need to focus on better treatments. The median tumor size actually tells us a lot about the system. So for example, if a country has an average tumor size that's quite large, 4 to 5 centimeters, that would be the case in Egypt or in India, then actually imaging, such as screening mammography, is likely not to be necessary because the tumors are already going to be ones that we can feel or see with our eyes. If, on the other hand, the median tumor size is small, less than 2 centimeters, then imaging is going to be the next step for improving outcome, whether it be mammography or some other image-based detection strategy. So knowing how large the tumors are provides a guidance to healthcare ministers on what they should be doing next in early detection strategies. But this is not the only measure. We could look at other measures. We could look at how many cancers do we diagnose, that would be incidence. We can look at the relative proportion, advanced stage versus early stage. We could look at the ratio of incidence and mortality, that is, for every case that's diagnosed, how many patients die. All of this is informative information. A limitation of the Global Action Plan currently proposed by WHO is it has no indicators and no measures, no targets, no specific mention of breast cancer, even though it's the most common cancer among women and the most likely reason that a woman will die, and even though the majority of these are taking place in low and middle income countries. So we are urging that metrics be adopted that can be recommended to member states. So overall, in terms of recommendations to the World Health Organization, we clearly have to think through our processes from a systematic approach. We, on the healthcare side, think of early detection, diagnosis, and treatment as the processes that we can influence. But actually, we need public participation as well. We need to produce survivors, because in many countries, it's believed that cancer is invariably fatal. These survivors organize into groups where they can advocate for resources for these cancers and can communicate to the general public about breast cancer awareness and the need for early detection. Ultimately, it's women communicating with women. It's the advocacy groups that will drive improvements in outcome. That's what happened in the United States. That's what happened in Europe. And we need to do this in low and middle income countries as well. When we look at the BHGI guidelines, there are in fact an essential list that must be placed, these basic level resources that should be applied. So breast cancer education, breast health awareness. Women need to know that when one has an enlarging mass in the breast, this might be cancer, that it's treatable, and that early detection is important. And similarly, we need to have healthcare education to our providers about clinical breast examination. They need to be able to perform a breast exam, identify abnormalities, and then refer them for appropriate workup. Workup is diagnosis. We need to have methods for tissue sampling. There are simple methods that are used, needle sampling techniques or removing the mass surgically. We do need to have pathology services. Without pathology, we cannot anticipate ability to treat. And a basic level test is hormone receptor testing. Knowing whether a breast cancer is estrogen receptor positive or negative makes a major impact. We have hormone-based therapies, tamoxifen. It's a generic drug. It's very affordable. But without the hormone receptor testing, we won't know which patients need it and which patients don't. We need basic surgical services. We need to be able to perform a modified radical mastectomy or breast conservation, that is a lumpectomy. But in that setting, radiation is necessary. So we need that available in the system if we're going to preserve the breast. And we do need drug therapies. In fact, it's the drug therapies that prolong survival in cancer and cure the disease. I'd love to tell you it's surgery, since that's what I do for a living, but in fact, it's the drugs. Tamoxifen is the main endocrine therapy, although one can consider removing the ovaries. The standard chemotherapy agents, CMF, AC, EC, FAC, these are standard chemotherapy regimens, and all of those drugs are already on the WHO essential drug list. This is not a new set of resources. These are existing resources being applied in a reasonable and intelligent way. And we need pain management. We do need drugs like morphine because there are many patients who will have untreatable or uncurable cancers because they're presenting at advanced stages. We need to be able to provide palliation to improve quality of life and dignity toward its end. I have an example from Peru of how we can use this basis of the BHGI guidelines to drive forward research. So the group Program for Appropriate Technology in Health, or PATH, is currently doing a project in Peru in which they're sorting out, based upon the BHGI guidelines, how to use basic level resources to triage patients and find them to refer them correctly to the cancer center without overwhelming it. In the northern area of Peru, the cancer center there is one cancer center in the northern region. But we need to determine which patients should ultimately go to the centers. So in this project, healthcare centers, where the women already come for reproductive health, the providers in these centers are being trained in clinical breast examination. When they find abnormalities, they're sent to the local general hospital where a fine needle aspiration can be performed. This is a type of needle sampling. When that fine needle aspiration is positive for cancer, it's those selected patients that need to make the 3-hour trip to the cancer center. And that's where they can receive the full-bore multidisciplinary care, which is appropriate and necessary. These type of research approaches are really important because ultimately what we need to do is improve capacity to help healthcare delivery, specifically focusing on breast cancer. And we should realize that when we improve these systems for breast cancer, this will have benefit for all the non-communicable diseases, the other treatable cancers like colon cancer, and for other diseases like diabetes and high blood pressure, where we need referral systems that makes the system operate overall. The goal in the Peru project by PATH is to create a model where national can be scaled up at the national level as part of their national cancer plan. So by having the BHGI guidelines providing this framework, countries like Peru can make improvements in a systematic way at optimal cost to save lives within their region. In summary then, Breast cancer is the most common female malignancy in the world. It is the largest cancer killer among women, and it disproportionately affects young women in low and middle income countries. The NCD Global Action Plan lacks recommendations that specifically address breast cancer mortality and morbidity, and in fact, at this point, we do not anticipate that there would be a shift or change on that basis. We can define an essential package for breast cancer in low and middle income countries that can be defined based upon resource stratified guidelines. And these recommendations are a starting point for these countries that are now reaching out to WHO and asking for guidance and help. A WHO recommended breast cancer metric, such as median tumor size, would permit member states to assess if and how they should address breast cancer in their country. We urge WHO to specifically address breast cancer in the Global Action Plan for Non-Communicable Diseases. It is the most common cancer killer. It is something that we must address, and this is feasible. We should not be pessimistic about the improvement of this very treatable disease. Thank you.